our tech talk this afternoon. We are really delighted to have our friend and colleague from University of Delaware, Mary Joan McDuffie, to give us a talk on the use of Medicaid data for research in Delaware. Before I introduce her, however, let me mention some housekeeping issues. As usual, we will continue extending CME credits for our tech talks today and also our ID series presentations next week. We will distribute the information via email to those who registered for today's event. If you did not register prior to today's talk, you can still obtain a CME code information from Deborah, and I'll write her email address in the chat in a minute. Our upcoming ID series and tech talks, we really have a wonderful lineup, and you don't want to miss any of them. Next week on November 11th, Katie Fitzpatrick, also from University of Delaware, will talk about does increased use of long-acting reversible contraception have unintended costs? And it's really a follow-up on Mary Joan's talk today. Then on December 2nd, we'll have another tech talk from Dr. Mustafa Oskenak from University of Colorado, who will talk about workflow analysis. And then on December 9th, we'll have also an ID series presentation from Dr. Kutili and Dr. Achimonji from Nemours, who will talk about homelessness in high school. So really, you do not want to miss all these presentations. So again, I'm really delighted to introduce Mary Joan, and I look forward to her presentation. Mary Joan is a Program Director of Medicaid Research at the Center for Community Research and Service at University of Delaware. She is also a policy scientist in the Health Policy Research Group, again in the Center for Community Research and Services. She obtained a Master in Urban Affairs and Public Policy from University of Delaware. She's a teacher and a mentor. She has been the lab instructor for the course Quantitative Analysis in Public and Nonprofit Sectors since 2006, and she also has mentored multiple students for their master thesis. She also has a long list of publications, reports to various state and nonprofit organizations, and also presentations. So Mary Joan, we are so lucky to have you today, and I can't wait.
Well, Claudine, thank you very much for that introduction, and thank you all for the opportunity to talk about Medicaid research, which is something that is of great interest to me. Let me share my screen. You all see that?
Yes, perfect.
Okay, good. Okay, so what I'm going to, not moving, wait, there we go. What I'm going to talk about today is kind of the background of the Delaware Medicaid research at our center, organizations that we're a part of, the data, uses for the data, and then to go over some recent Medicaid projects to illustrate on how we've been able to use the data and link it up with other different data sets. So why is Medicaid so important? As I think most of you all know, about 25% of the Delaware population is covered by Medicaid, but it has an outsized importance for certain portions of the population, such as children. About 50% of the births are covered by Medicaid. So it's covering a vulnerable population, low income, people with disabilities, pregnant women, a very important program within Delaware. So some background on how we got into Medicaid data research. It first started in 2011 with a memorandum of understanding where we were contracted by the state to look at emergency department use. That grew into a partnership agreement that was signed in 2016. And the intent of the whole partnership agreement, and this is very important, is to provide research on Medicaid that's beneficial to the Delaware Medicaid program. So any information that we get, we want to be able to provide to the state and to help us all understand the Medicaid population. So we don't own the data. Anytime we touch it, it's with the permission of the state. and again, to benefit the program. So we're part of the State University Partnership Learning Network. This is an organization started by Academy Health in about 2014, and the university's been a member since 2015. And this is partnerships of universities and states that have similar agreements that we do in looking at the Medicaid data. It's a great collaboration, a lot of share information and collaboration. Some of them have been partners that have this type of partnership for over 20 years, like Hilltop Institute at the University of Maryland, Baltimore campus. And some of them have just started their partnerships. There are actually 25 states that now are part of this network, and with 30 active partnerships. Some of the larger states have more than one partnership. An offshoot sub-study of the SUPLIN, the State University partnership, is the MODERN, which is the Medicaid Outcomes Distributed Research Network. This was started about 3 years ago, and the focus of this first project is opioids, which is so important. It started out with 9 states participating, and it's now up to 13 states that are participating. So for those of you that are not knowledgeable what a distributed research network it is, it's everybody takes control of their own data. No identifiable data is shared across the states. There's a common data model, so all the states reformat their claims data into a data set with the same names, same measurements. There's a data coordinating center that's out of the, for this project, is out of the University of Pittsburgh. Dr. Julie Donahue is the PI on that. There's a steering committee that is made up of all representatives from the Medicaid programs among the states. There's a methods core that goes over every single measurement prior to it being implemented, searching the literature, etc. And then there's shared SAS code that is generated by the University of Pittsburgh that is then given to all the different states. So we're all running the same measurements off the data. It allows us to give more up-to-date data than other avenues to Medicaid data, like the TMIS system. And it allows each of the states to use identifiable data at the state level, and then we share de-identified data with the other states. Any publication or anything that comes out of the research, the states are all masked, and it's the aggregate data or the pooled prevalence rates that they're really looking at it. Because of this distributed research network, legal ramifications are easier. We don't have to do DUAs among all the 13 states that are involved because we already have agreements with our states. And it's a brain trust. It's just kind of amazing to me from the Medicaid side and the university side, all the different policy implications that the different researchers are aware of. It's really an extremely cool thing to be a part of. We're also part of Delaware INBRI. Have been for about 2 years, and it allows us to collaborate with other researchers, especially clinician researchers at Nemours and Christiana. And several of the projects that I'm going to talk about today were funded by INBRI through their Core Access Awards. So shout out to Claudine. Thank you very much. This has been a great opportunity to work with different research partners. So the Medicaid, what we have is the Medicaid administrative and encounter data. Encounter data, that's important to note because Medicaid's mostly managed care. One of 40 states in 2019 had some sort of managed care within Medicaid. Our rate within Delaware, according to the Kaiser Family Foundation, in 2018 was running about 84% managed care. So we get both fee-for-service and encounter claims within the data set. So an overview of what exactly is in the data set. We get medical claims, which have 17 diagnosis codes, which is based off the ICD-9, ICD-10. We get HCPCS codes, procedure codes. There's 6 of them. Current procedural codes, place of service, so we know if it's in a hospital or an ED, etc. The starting and ending dates of services. Get header claims and detail claims. So, for example, if you're in a hospital and you have more than one provider, we will see those claims, and we get costs. We also get prescription claims. We get the drug codes, again, cost, referring provider, date of service. Eligibility files, months of eligibility, aid categories, address, and client data files. We get the demographics and also get provider files. And there's a master client index, which allows us to link up these 4 files. The basic demographics that we get are client sex, race, ethnicity, county, address, birth date. And you'll see in illustrations of the different projects that we've done that we're able to merge other different data sets with the Medicaid claims, which makes it even more interesting to look at it. So uses for Medicaid data. Evaluate the impact of various programs, initiatives, policies, monitor changes in the Medicaid population, and the biggest thing, examine healthcare utilization. And a lot of the states use their Medicaid data to identify and impact the effectiveness of Medicaid spending. So what project decisions are made each time a project is done? Look at aid categories, whether we're looking at people with full or partial benefits. Number of months eligible, sometimes that is dictated by outside research. The DELCAN contraceptive intervention evaluation that we're doing, the Office of Population Affairs has women have to be in the system for 11 months. We look for appropriate diagnosis procedure codes, or NDC. Usually the background from those are from other literature or from clinicians who have experience in the field. And what years of data. The de-identified data is removal of dates, geographic identifiers, names, and unique identifiers. We're not allowed to create any de-identified file that contains any of those variables. So this lovely flow chart is kind of my anatomy of a project. Somebody comes up with a project idea. Obviously, there's discussions between funders, between the Medicaid research team itself to see, is this a viable plan? Discussions with DMMA, because as I said, this is projects that are Medicaid research through our center are for the benefit of Medicaid. We do a project agreement, official project agreement. We go through the university IRB approval, project implementation, and then we submit all products to DMMA for review to make sure that we've understood the Medicaid policies correctly. And then there are sometimes public release of products. The guidelines that we follow, the CMS suppression policy, which states that no cell can have 10 or less of a count in it, or any of the cells you can't infer what that missing cell was. Any de-identified file, there's 2 ways to do a de-identified file. One is through expert, knowledge saying that, okay, I'm pretty sure that this file can't be reveal any identifiable information. We use the safe harbor method because that's guidelines through HIPAA of removing 18 different variables from any de-identified file, and that way we're very certain that the file has been de-identified. So now I'm going to go over some Medicaid research projects. Some of the items that I'm going to go on have been publicly released, and others I'm just going to go over like the generic how the project is organized to give you an idea of different Medicaid projects and different ways we brought in other data sets. Our biggest project is the Delaware Contraceptive Access Initiative Evaluation. We are in our 6th year and supposedly our final year of this evaluation. We're collaborating with the University of Maryland, who's the PI on this, and also other groups. We're a small part of it. Other groups are the Center for Drug and Health Studies that are doing qualitative interviews, and also Dr. Ann Bell over at Department of Sociology at the University of Delaware that is doing another aspect of qualitative interviews. And so the intent of the initiative was to reduce unintended pregnancies. Delaware actually was number 1 for a while. We've come down a lot. Second intent is reduce Medicaid costs for unintended pregnancies and support policy that enables contraceptive access to any women within Delaware. The initiative started in 2015 about and has different aspects of it. Separate reimbursement for LARC devices through Medicaid, so allowing women to get immediate postpartum LARCs. The pilot project at Christiana Care, which also gave access to LARCs for immediate postpartum. DPH funding for Title X LARCs. The upstream training of providers started in about 2016. There was a Be Your Own Baby public awareness campaign between 2017 and 2018. So we had the Medicaid data. We pulled out women that were identifiable for births. The Division of Public Health matched that up to birth certificates for us and also followed whether the woman had a subsequent birth, whether it was paid for Medicaid or not. Also brought in the PRAMS data for those women that had been surveyed by PRAMS. We were given a limited data set from Maryland Medicaid data, which we're using as the comparison state through difference in difference analysis. We received CCH pilot data identifying the women that had participated in their pilot project. And we're also bringing in the American Community Survey data at the zip code level to be able to give us more of a flavor of the different areas that women are from. Different analysis that our group, CCRS, is doing with the University of Maryland is we've looked at short interval pregnancies, postpartum contraceptive use, and contraceptive cohort contraceptive use, and provider training. So one of our first studies was the Power of Mom that we did, and we looked at the research question was influence of mothers on women's contraceptive utilization. So Dr. Ann Bell at the Department of Sociology did in-depth interviews with 86 women to explore mothers' influences on contraceptive utilization by the younger women, and found through those interviews that there was definitely an influence from mom. So we looked at the Medicaid data to see if we could replicate that. for 2012 through 2015, and we grouped likely mothers, daughters. We don't have relationships within the Delaware data. So our proxies were identified as women ages 15 to 44 years old, and there had to be at least 15 years between the mother proxy and the daughter proxy, and they had to have the same household identifier. You can see from the graph, from oral contraceptives, the daughter was 2 times more likely to have oral contraceptives if the proxy mother had it. Injectable, also 2 times more likely to have injectable if the proxy mother had it. And the LARC, the daughter was, proxy daughter, was 2.8 times more likely to have LARC if the proxy mother had it. We also have a publication on short inter-pregnancy interval, and our research question was the association of the type of contraceptives with short inter-pregnancy interval births. This graph is showing a kind of survival analysis and comparing the women with LARC to moderately effective method claims like oral contraceptives and no contraceptive claim. We cannot see over-the-counter birth control. We can only see if it's prescribed, so no contraceptive claim really should be interpreted as no prescribed contraceptive claim. But you can see that this top line with the LARC, definitely there's more times between a month between the index birth and a subsequent birth. So only 2.7% women had an IPA shorter than 12 months, in contrast to 8.6% of the women with the moderately effective method and 12.2% of the women with no contraceptive method, prescribed method at all. Again, mentioned the multi-state opioid study. And again, there was 11 states doing analysis, and then giving de-identified aggregate data to the coordinating center. You can see from the map, most of the states are East Coast, but 6 of the top 10 states have drug overdose death rates in the top 10. So it's representing about 16.3 million people ages 12 through 64, or 22% of Medicaid enrollees. So this publication just came out recently on the multi-state opioid. And just some background, the majority of the clients with OUD were in the age range of 12 through 34. About half of them were covered by 2018 by the Medicaid expansion. About half of them had other substance abuses, and almost 2/3 of them had a mental health condition, and about 2/3 of them lived in an urban area. The pooled prevalence of those with OUD, that's the dark line in this graph, increased from 47.8% in 2014 to 57.1% in 2018. So there was an increase of MOUD among those Medicaid clients with OUD. The blue lines on the graph you can see are all the individual states. We do not label the states. As I said, the states are masked. So you can see there is a bit of variation, but it does look pretty consistent among the states that there is an increase in MOUD. There were some disparities found from this study that Black enrollees were considerably less likely than white enrollees to be treated with meds or MOUD or their OUD disorder, and were less likely to have continuity of such treatment. Pregnant women with opioid use disorder, on the other hand, were far more likely than other clients to receive continuous MOUD, which kind of makes sense since pregnant women are more hopefully involved with the health system. Other analysis that are in the works is looking at the duration of MOUD and the risk of overdose, follow-up of ED, and is that reducing overdose, residential treatment, HCV, HIV, HBV screening against pregnant women with OUD. We're also doing a study on homelessness. I don't have any public results from this, but just to give you, for these next couple projects, an idea of how they're set up. We received the homeless data from the Housing Alliance. This is based off of shelter information and programs. We're able to merge it with the Medicaid data, and almost 3/4 of it had a successful merge. We use propensity scoring to create a matched comparison group. Then we use the comorbidity index to control for, because obviously someone that's sicker is going to get more costs. The comorbidity index includes things like alcohol abuse, cardiac arrhythmia, pulmonary disease, heart failure, and we use it as a control, along with other demographic variables. Another project funded by IMBRI is hypertension among African Americans. We obviously identify African American clients with hypertension through ICD codes, code the addresses to the census block, and then we're able to merge it with health literacy scores. The health literacy scores come out of the University of North Carolina, Chapel Hill, their health literacy project. And the research question is that health literacy will impact health utilization and prescription adherence for African Americans with hypertension. Cost of low literacy is extremely high, estimated to be between $106 billion and $238 billion per year, and influences whether people are adhering to prescriptions, self-care, following health instructions. So it's an interesting data set to bring in with a Medicaid research project. This project that's undergoing now is we're looking at a pilot project with the Delaware Department of Corrections that has started, that has an MOUD project so that individuals incarcerated can receive MOUD while they're incarcerated. So our research question, and we're working on this with Johns Hopkins, is did the program impact the use of MOUD overdose events after release? So we're comparing those that are in the pilot project to other prisoners who had OUD prior to incarceration to see if the outcome after incarceration is better for those that were in that pilot project. Another hypertension project, another IMBRI project we're looking at is children, identifying children with hypertension. This time we are geocoding the addresses to the census block group and bringing in the ADI, the Area Deprivation Index. And this is based on a measure created by Health Resources and Services Administration at least 30 years ago, and has been refined by people at the University of Wisconsin-Madison. And so it allows for rankings of neighborhoods at the census block group for socioeconomic disadvantage. So it's an example of another data set that is being merged with the Medicaid data that gives more context to what's going on in the neighborhood of social determinants of health. And we're looking at health utilization and prescription adherence with the research question is that higher ADI will be associated with higher prevalence of HTN among children. Another project that is almost completed is the sickle cell. We're looking at sickle cell. We didn't merge any data sets with this, but this I wanted to bring up to illustrate how identifying somebody with a condition can change the number of people that have it based on your definition. So with the sickle cell, we actually did three different methods. The first is the least stringent. The third is the most stringent. In the first one, the client had to have at least one claim with sickle cell diagnosis during a 5-year period. In the second one inpatient or 2 outpatients. And the third one, we used the CMS warehouse, which is a chronic condition data warehouse method. And in that case, the CM warehouse actually provides the ICD-9 or ICD-10 codes for the condition and gives a definition of what they consider someone who has this. And in this case, the client had to have 3 or more non-drug claims during the 5-year period in order to be identified as sickle cell. And as I said, through each narrowed criteria, the number of people identified with the condition gets smaller. And the last study I wanted to show, because it brings in that we've combined the Medicaid data with a Nemours data set. And our interest in this is to see how many children with elevated blood levels, are one identified in the Medicaid data that have been identified in the Nemours data set, and so establish a match rate with the Medicaid data, and then also identify, okay, if they're in the data set, are the lead tests and the lead results as indicated by ICD-9 and ICD-10 codes similar or different between the Medicaid and the Nemours data. So I'm from a large family, so I talk fast, so hopefully I didn't go over this too fast. This is who we are at the CCRS. We have Dr. Katie Gifford, Becky McCall, Aaron Nescott, and Dr. Steve Metro are our core people on the CCRS Medicaid research team. And as you'll see next week when Dr. Fitzpatrick presents, we collaborate with different researchers at the university and at Nemours and Christiana, College of Health Sciences. And hopefully the presentation today shows you the possibilities that different Medicaid research is doing among different states within the nation and the collaboration that's going on between different organizations. So thank you, and I guess I should stop share and see if there's any questions.
Thank you so much, Mary Joan. Any questions about Medicaid research? And I must say that it is a very active program, and Mary Joan leads a very busy team on multiple projects.
Claudine, this is Scott. I had a question, but I can't seem to get my system preferences to allow me to turn on my camera, and I don't know how
Go
else to
ahead,
see
Scott.
it. Okay. Well, thank you for the presentation. This is really interesting and relevant to some projects we're contemplating. My understanding is that because of the privacy protections, a question and the methods would have to be worked out in advance, and then it's sort of turned over to your center, and then the analyses are conducted, assuming funding and all, but the analyses are conducted, and then only sort of aggregate descriptive statistics or results are produced as a way of protecting privacy. Do I have that in the big picture correct?
Yes, for the majority of projects, that is true. We have done projects where we've done de-identified data sets and given them to the researchers, but that in itself is got a lot of problems, especially since we can't give you dates.
Right. Well, I was also thinking about locations. A lot of the work we do is related to locations, so we wouldn't, a de-identified data set wouldn't be helpful. So what do you do in the case where maybe there's a more specialized technique or method that an investigator wants to employ, but that's not necessarily something that people in your center may have experience with?
Yeah, good question. We've worked with the biostatisticians over at the College of Health Science,
Okay.
have helped us out with that. And then we're always willing to learn new things.
Right, but it wouldn't be like if there was somebody from an outside institution who knew how to do a particular technique. Is there any mechanism for that person to become a part of the center so they could do the analyses on the non-de-identified data?
No, there's not. Each one of us have a business associate agreement, individual business associate agreement with the University of Delaware. I'm sorry, with the state.
Okay.
So I'm not saying never ever, but usually no, that is not the way we don't. We also have dedicated Medicaid laptops, which are only used for our Medicaid research
Hmm.
and nothing else. We're not allowed to get on the internet with them or anything.
Perfect.
So yeah, that would be hard. However, if such a project was approved, we definitely would be open to, the person could write the mock SAS code for us and
Okay. Okay.
and follow it.
Okay, that's helpful. Thank you.
Hi, this is Kim Williams. I work with Claudine and Scott in iReach at Christiana Care. And I think Scott's question answered my question, but I just wanted to follow up to just get clarification on that. I've been very interested in the Modern project that has been ongoing and produced really interesting findings, and thank you for sharing some of those today. How does that program work? Like, is it possible to become an affiliate, through your center, if I'm at Christiana Care, to work with you and maybe collaborate and answer some questions through that network?
I don't know. That's a good question. We would have to ask the supplement people, and we would have to ask the state people. And I just a shout out to somebody that's extremely important at the state is Liz Brown, the medical director at DMA, who's very involved in all the Delaware Medicaid research that goes on. So I'm not sure. I would have to talk to supplement people, but you wouldn't be able to see the data, but I don't know if they would be against you, like, joining the group.
Okay, thank you.
But yeah, I can investigate that.
Okay, yeah, and I'll follow up with you directly, Mary Joan, to talk with you more about that. And since you're shouting out to Liz Brown, Dr. Brown as well, and maybe I'll reach out to Liz as well. So heads up on my emails, please. Thank you.
So since I've been called out, would it be okay if I made some comments?
Absolutely.
Yes, please.
Okay. So for those of you I don't know, I'm Liz Brown. I'm the Chief Medical Officer at the Division of Medicaid and Medical Assistance, and a former colleague of several people on the call, and also returning from maternity leave this week. So I'm still catching up on a lot of things that have happened in the past couple of months, but so. We do work extremely closely with Mary Joan. We have regular meetings and lots of ad hoc interactions, and it's been a great partnership. I think there's I think the Medicaid claims data can be a really powerful data set for the right questions. I think there are a lot of things that you need to think about when you're dealing with claims data. One is that, and the part of the reason that the Nemours-led screening project has been interesting is because there is a clinical data component that's being matched with the claims data. So claims data, as I'm sure most people on the call know, doesn't have all of the information that would be in an electronic health record. So we don't have lab results. We have whether someone has put in a diagnosis of elevated lead level, but we can't, you can't look at claims and necessarily see, oh, this lead level was, 5.2 or whatever. It's also, the medication, in some ways you can do some great longitudinal studies for certain conditions or for certain populations, but it does not work as well for other populations that may have a lot of churn. So people who may bounce in and out of Medicaid eligibility. So, you have to be really thoughtful about whether the amount of time that someone has been enrolled in Medicaid, the snapshot that you're, that you really need to be able to ask the question that you're asking. There's also, Delaware is a small state, and the Medicaid population is a decent percentage of the state, but it's still just a percentage of a small state. So then if you're looking at relatively rare conditions or procedures, you run into the issue of small numbers. And in particular, Scott, you mentioned like geographic analyses. Once you get down to very small geographic units of analysis, we often run into the less than 10 CMS suppression rule issue. And there is also the encounter data versus fee-for-service data is something that, to be perfectly honest, when I was doing research prior to joining Medicaid, I did not understand what the difference between those two. But we really do. So encounter data is claims that have been processed by our managed care organizations, and then those completed claims are reported to the state as an encounter. There are lots of checks that those those encounters need to go through before they get sort of accepted into the Medicaid system. So timeliness is an issue because sometimes a service was received, but there's some issue with the encounter. So the encounter doesn't appear necessarily in our data for, a couple of months or even longer. So, just one comment on the managed care prevalence in data or in the state. So our managed care program covers the vast majority of people who have full Medicaid benefits. So it's in the high 90% of the people who have full Medicaid benefits. It's lower when we're looking at people who are dual eligible, so have Medicare and then some partial Medicaid benefits. So I think that's where the Kaiser Family Foundation number in the 80s comes from, because the vast majority of our population, once they have been enrolled, are on fee-for-service for an extremely short period of time before they get enrolled with a managed care organization. So just some thoughts off the top of my head. Yeah. Thanks.
Thank you so much, Liz. Yeah, this is very important. Thank you.
Hi, my name is Peter Coyle. I'm a researcher in the Department of Physical Therapy. I have a few questions about the data set and the possibilities with the data set. The first one is I guess a good follow-up to Dr. Brown's point. So we study older adults in the lab that I work in, And I was wondering if you have encountered data for folks who were dually eligible, Medicare, Medicaid. So I guess I'll just pose that as the first question.
We do, but you have to remember for that group, since they're dually eligible, we're not going to see a lot of their health utilizations because we do not have the Medicare data.
Right. So my question, I guess, is more broadly, like if they're admitted to the hospital, my assumption is that those costs will be split between Medicare and Medicaid both.
I think Medicare picks them all up. Liz can correct me. I think Medicaid more or less pays for long-term care for the dual eligible.
Yeah, I mean, it depends a little bit on the program, but for the most part, hospitalization is probably going to be like
under Part A.
Part A. And a lot of it is going to be Medicare claims. And then some of the things that aren't paid for by Medicare would then be paid for by Medicaid. But it will only show up as an encounter if they are fully dual. So it's the bottom line is we don't have the Medicare claims, or at least CCRS doesn't have the Medicare claims, and we don't really have a good way of sort of understanding what Medicare has paid for on top of whatever we may see in the Medicaid claims.
Okay. Next question is behavioral health benefits. I know that some states cover behavioral health benefits through Medicaid and some don't. Is Delaware a state that covers behavioral health benefits?
Mary Joan, do you want me to take that one, or do you want to?
I was going to say yes, we do have behavioral health in there. I know there are some carve-out projects that we might not be picking up. So, Liz, do you want to?
Yeah, so in general, if we're talking about adults, behavioral health is covered and it's carved into the managed care benefit. So basically, the same managed care organization would pay for physical health services and behavioral health services. And, we do have pretty comprehensive behavioral health coverage. It's a little bit different for children, and this gets fairly complicated. But for kids, the first 30 outpatient units of behavioral health are carved into the managed care organization. So the MCO would be responsible for 30 units of something like outpatient psychotherapy or something like that. But anything that's a higher level of care or goes beyond 30 units, so any like inpatient services or things like that for children become the responsibility of the Department of Children, Youth, and Families, specifically the Division of Prevention and Behavioral Health. So the short answer is it's kind of complicated for kids. For adults, yes, we have carved in behavioral health coverage.
Gotcha. Thank you. And then the last question I have is longitudinal data. I know that you said dates are not available, but are you guys able to do like an honest broker like proxy date? So you have like an index visit and then days past index visit or anything like that?
We have done that before.
Okay.
When we look at data, that as I said, we don't do too many de-identified files that are given out. But the last one that we gave out, we actually did do some sort of proxy so that the person would know how much time between an index event and another event happened without revealing the date.
Okay, that's great. Thank you.
And Claudine, I wanted to ask you about Medicare because Peter brought up Medicare. Don't we have access now to Medicare data, or was that not done?
Yes, so we have access to Medicare data through the DIN, through the ACCEL at the DIN, at the Delaware Health Information Network. But not for, we cannot go back, many years, and it's only for Delaware also.
Thank you.
Dr. Nellinger, did you have a question?
I did have a question. I'm Abby Nerlinger. I'm a pediatrician at Nemours. I just was wondering if you could talk a little bit more about the cost data, especially given that such a high percentage of kids are on managed care contracts.
The cost data we haven't done a lot of with. We've gotten it since we started getting it in 2018, and it's actually supposed to be the paid cost that the MCO pays the provider. So it's not the billed cost. It's not. We do not have capitation rates, but it's supposed to be the actual amount that the MCO paid the provider for the service. So we also have billed amount, which is really interesting to see the difference between paid and billed. But
okay.
So Liz, I want to thank you for your answers. You didn't know you were coming back from maternity leave to present, huh?
No, but this is actually a great opportunity. So I'm glad it worked out.
Yeah, no, I'm very happy that you were here to answer the questions. And this is again an illustration of why we partner with the Medicaid agency, because they know they know with the in the weeds information about the policies and also about the data and idiosyncrasies, and I think that's why Modern is so great of a project.
Yeah, I think it's been really helpful and eye-opening to see how different coverage is amongst different states, and how the very nitty-gritty details of how the policy is written can really affect how you need to analyze the data, and under what categories particular services will fall. And I think that's one of the great benefits of the sort of the distributed research network model, is, it sort of levels the playing field so you can make comparisons. Sorry for the noises in the background. And it's been really, I think it's been really helpful. But it also has helped us identify things about the way we approach analyses that, we need to be cognizant of and may not have realized. So I'm going to go back on mute now.
Thank you so much, Liz. I'd like to remind also everyone that there are opportunities of funding to access, to have the help of Mary Joan and her team through the INRAE Core Center Access Awards. And, it is explained on the INRAE website. That's something that we manage from Christiana Care. But it is INRAE Core Access Award. It is a mechanism from INRAE.
Yeah, it's a very valuable one. As I said, a lot of the projects that I presented, the overview of how they were structured today, were funded through INRAE, and have given us the possibility of working with different researchers at Christiana and Nemours that we might not have the opportunity to work with before.
Yeah, I think there are some of the projects that you showed where had been funded through these Core Access Awards, and I know that there had been some that were really, really interesting.
Mm-hmm.
And I think there is a question in the chat about collaborations with the Delaware Healthcare Claims Database. Yes, we do. We also have developed a mechanism for Core Center Access Awards from HCDD, so the claims database that is managed by the Dean. If you need any information, please let me know. I think I forgot. I'm going to put my email in the chat as well as Deborah's email. Any other question, meanwhile, for Mary Joan?
I'm sorry I missed most of the meeting, but could I ask a question?
Sure.
Sure.
I do some research with women who've been abused, and they can cycle in and out of prison to homelessness. Those are the two populations, the prison and the homeless, where I access them. But I'd like to get a wider data set of abused women. Is there a way to collect that in the Medicaid data?
I know there's some ICD codes, but I'm not quite sure. We've never done any research on that, so it would be something that I would have to investigate. Again, as Liz pointed out, Delaware's a small state, so I'm not sure at the end you might have to pull data over several years in order to be able to look at something like that, but definitely something that can be investigated.
Okay. I guess that's not a standard question anywhere about abuse scale or anything, to know adverse childhood experiences, because that's really prevalent in the lives of people that it's never been collected. But if you go back and do a survey of the general population, it's huge. So I guess our Delaware data, there's nothing that's measuring that, probably, right?
No, we don't measure the ACEs, but there are social determinants of health ICD codes. However, investigation that we've done of them before is they're not reliable because they're not being filled out as much. Because, let's face it, people's lives are busy, seeing clients and stuff like that, and it's kind of a wider thing to start filling this out. I do know that there's been an uptick in the people that have been indicating homelessness, though, on the diagnosis code. So that is one that has increased. But the other ones, every time we investigate it, the N is so small that it's not really worth looking at.
Is there a list somewhere of the variables that could be evaluated in relationship to the homelessness?
That I would do research, go on the web. If you just do a search on social determinants of health, ICD-10 codes, I think they're the Z codes, and then it'll come up. And there's really only one, I think there's two. One that is homeless and one that is housing, housing's in jeopardy or something like that. But as I said, unfortunately, too often they're not filled out.
Okay. Looks like I'm just going to have to keep going to the population myself and getting the details.
Yeah, unfortunately.
I think that there are some comments in the chat related to ACE provided by Dr. Pachter. You may want to look at the BRFIS data for experience of violence. The BRFIS, BRFSS.
Oh, yes.
Okay. And Dr. Pachter mentioned that so the BRFSS has statewide ACE data.
And how can I access that for the state? I can't see the chat.
It's public domain. If you enter BRFSS, I'm sure you'll find it. It's public domain.
Yeah, I believe this is a CDC database, national database, and they do have it broken down by state, and I believe each state has the opportunity to ask ACE data, and I believe that Delaware does have that data.
Okay, yes, I've seen that in the past, the BRF. I'll have to look at what else is collected in relationship to those things in order to look at the various risk factors and that are increased with homelessness or that are risk factors for homelessness.
And Erin Lynch says that Kids Count also has some valuable ACE data, and and she provides the link. We want to look at the chat.
Yeah, I can't. How do I access the chat on this? I don't see it.
So your top right-hand side might have it, but I can email you as well.
Right, I can't access it.
Erin, if you don't mind emailing it, that'd be great.
Yes. Kathleen, are you comfortable sharing your email? I know you can't really use the chat.
Yes, it's just kbsmyth@udel.edu.
Oh, yes. You'll come up in our database. I'll shoot you an email.
Thank you.
Erin, this is Kim. I put the link to the Burfus data in the chat. Would you mind just tacking that onto your email? Thank you so much.
I'm on it. Yep.
Thank you.
Thank you, Erin.
Absolutely.
All right. Well, this was a wonderful discussion. Thank you so much, Mary Joan. And we'll see you next week. Don't forget Dr. Fitzpatrick's talk, which will be also fascinating. So thank you again.